termination of resuscitation, all right? There's termination of resuscitation rules in the protocol for both medical patients and for trauma patients, and they are quite a bit different. So again, let's think about a little scenario to get our minds moving. Let's say that we're called to a house, and it's a 25-year-old guy, and it's a suspected heroin overdose. Okay, unfortunately, we see a lot of this nowadays. The patient was found by the mother early in the morning. Don't know, he was last seen last night. We don't know any other details, but maybe mom even says, oh yeah, he has a history of heroin abuse. We get there, and that initial rhythm is asystole. What do we do now? Okay, can we just stop? Can we just say, oh, it's over? Okay, probably not yet. Now again, if that patient has signs of being dead, i.e. dependent lividity, rigor mortis, then right, now they meet those categories, we can stop. But if we don't see that, right, we got to start resuscitating that patient. We can't stop yet. We gotta start working, okay? And this is where the termination of resuscitation rules, how long do we need to go? How much do we need to do before we can say, okay, it really is hopeless? Before we get into that, let's just stop for a second and think about, why do we have termination of resuscitation rules? I mean, why not say, hey, there's a cardiac arrest, we got to do everything, we got to bring him to the hospital. Why do we even have these rules, right? Pretty important. There's a number of big reasons why we do. Number one would be going, level 3, going lights and sirens, whatever you want to call it, to the hospital, right? I mean, many of you know there are risks in doing that, right? Ambulances get into car crashes every year, responding lights and sirens, going through intersections. It's not without some risk, both to the patient and, of course, to you all as medical providers. And so it is not without risk that we go lights and sirens. So we don't want to go lights and sirens unless we have to, unless it's really worth it. And under these particular situations that we're going to describe when we are allowed to terminate resuscitation, okay, we're going to say it's not worth it anymore, okay? Also, as many of you know, CPR in the back of the ambulance is probably not the best. Now, I know a lot of people in the area have started to get various mechanical CPR devices, and, I'll give it to you, those are pretty cool, and they will, potentially enable high-quality CPR in the back of a moving ambulance, but I still don't think it solves all problems. There is still a level of intensity that comes with that resuscitation when you have, 4, 5, 6 medical providers around that patient, on a stable floor that's not moving, just in terms of, how well are we managing that airway? How aggressively are we giving meds? How, quickly are we defibrillating when indicated? How much are we really paying attention to that patient? It's been my experience that as soon as that patient gets moved into the back of the ambulance, that resuscitation quality really goes down. Not just the CPR, but just the whole resuscitation quality goes down. So I don't think we're doing anybody any favors by throwing them into the back of the ambulance and trying to hightail it to the emergency department, except for some maybe very specific situations. This is why, of course, for many years we have said, cardiac arrest, we're going to stay and play. Right? That's what we always talk about. We're going to stay on scene and we're going to work it on scene because we know that transport to the ambulance is going to be low quality. That resuscitation is going to be low quality, even with a mechanical chest compression device. And now we're giving them low quality resuscitation during the early minutes of resuscitation when they need our A game. So that's not a good idea, okay? It's also probably a poor use of resources. Depending on where you practice, maybe your ambulance goes out a lot, right? And so if we're going to spend all this time transporting someone, and getting to the hospital and giving report and cleaning up and all for someone who, really has no chance of survival, that's a pretty poor use of resource. And ultimately, these termination of resuscitation rules are trying to define which patients is just futile. There is no reason to proceed. No matter how hard we try, we are not going to get this patient back. They are not going to walk out of the hospital, and so we may as just stop. All right, so that's why we do termination of resuscitation rules. Now remember, there's a termination of resuscitation rules for medical patients, and then there is a termination of resuscitation rules for trauma patients. So let's now go over the medical protocol. So again, let's imagine our scenario, 25-year-old patient, likely heroin overdose, found in the morning by his mom in cardiac arrest. Initial rhythm is asystole. What do we need to do? Well, actually, I probably should have put 30 minutes of resuscitation at the top now that I look at my own list, right? That's number one. Number one is we need to do 30 minutes of ACLS. We got to do all the things we know how to do, all the things we trained to do. We got to do high quality CPR. We, potentially are giving medications, managing the airway, getting intravenous or intraosseous access, whatever, defibrillating, et cetera, et cetera. You know what to do. We're not going to review ACLS, okay? We need to do 30 minutes of resuscitation, okay? If after 30 minutes of resuscitation, we still have no pulse, that's when we can start thinking about termination of resuscitation. Okay, what do we need to do to be allowed to terminate? Okay, you need to have good contact with the physician. As most of you know, right, you're going to call into one of the hospitals. You can always call into the University of Cincinnati Medical Center, but other hospitals will take this call as well, okay? And you need to talk to the physician. You need to have good contact. If for some reason radios are down or whatever, you can't get in contact with the physician, well, then you can't call it, okay? So we need that, okay? We need to manage the airway somehow. Okay, that doesn't mean that they have to have an endotracheal tube or a supraglottic airway. Okay, a bag valve mask is fine. That is a whole, debate in and of itself that we're not going to talk about. But you just need to make sure that you have managed the airway and you feel like you are able to get breaths into this patient somehow. Okay, and so long as it seems like the airway is not the issue, then that's fine. We can move forward. Okay. We need to not have ROSC for greater than 5 minutes. So ROSC, return of spontaneous circulation, okay? If they had a brief ROSC, sometimes that happens in the middle of the resuscitation. Oh, wait, I think I have a pulse. Wait, I don't know. No, I think I just lost it. Okay, that doesn't count. Technically, ROSC, it needs to be at least 5 minutes, okay? But if you've had ROSC for at least 5 minutes at some point, then you cannot terminate. That patient needs to go, okay? Because they're demonstrating that they have a fighting chance here, so we need to give them that chance, okay? They need to obviously be comatose. I say GCS3 here, okay? What I'm really trying to say there is that they can't have any signs of neurological activity, right? Maybe some of you have seen it before where you do CPR, and while you're doing CPR, the patient is actually waking up a little bit. Maybe they're moaning a little bit, or they're blinking their eyes a little bit. Maybe there's a little bit of motion or something like that, okay? We can't have any of that. Those are signs of life. That, again, is evidence that this patient has a fighting chance. So that one we're not going to terminate, okay? So this patient should be doing nothing. Nothing. There is no neurological activity at all, okay? The rhythm cannot be recurrent ventricular fibrillation or recurrent ventricular tachycardia, okay? It's okay if they initially had it. If you arrived on scene and they initially had a shockable rhythm, but maybe you shocked them and then they were in PEA and now they're in asystole and they're in asystole, that's okay. But if they, you can, and by okay, I mean you can allow, you can terminate resuscitation on that patient, okay? But if they are persistently in a shockable rhythm, that is, again, evidence that that patient has a fighting chance. We do not terminate in the field on that patient, okay? Everyone has to agree. This is actually not, a small deal. Before I stop a resuscitation in the emergency department, I ask the entire room if anyone else has any ideas or if anyone else has objections to stopping the resuscitation at this point in time. So the whole team should be in agreement. This is not a decision we're going to make, by vote. 51% of us thought to stop. No, everyone has to agree that we're going to stop. Everybody has to feel like we did everything we could. And then finally, there's 3 exceptions in the protocol, okay? Hypothermia, electrocution, and a lightning strike you cannot call in the field, okay? That is because some of these patients, especially the electrocution and the lightning, they may look dead, but they may actually still be survivable. And similarly with hypothermia, some of you know, there have been case reports over the years of, patients who have fallen under the ice, have been pulled out of freezing cold water hours later and have walked out of the hospital, right? So hypothermia is a unique scenario. That's actually what led to research on therapeutic hypothermia, right, which we now do for patients that have a pulse back. So those are the exceptions. Keep in mind, this is, again, hypothermia that sort of led to the arrest, right? I'm not talking about, maybe the patient's been dead for a while. We thought we were going to find dependent lividity, but we didn't. But they seem kind of cold, and so that's not the hypothermia I'm talking about, okay? If it's just you think they're cold because they've been dead for a while, but you couldn't find evidence of being dead, okay, you can call that one. But hypothermia causing the arrest, that one you cannot call in the field. That one gets transported, all right? So if they have to meet all of these criteria, right? 30 minutes of resuscitation, and then all of these criteria. If they meet all of these criteria, then you can call the physician and ask for termination, and that is reasonable. All right? So that is our medical termination of resuscitation rules. Few difficult scenarios here, right? There's always some messy scenarios. Let's think about children for a second, okay? This is difficult, right? By the protocol, if you have a pediatric patient who's in cardiac arrest, you can do a full 30-minute resuscitation on scene, do everything possible to try to save that child, and if we are still not successful at getting a pulse back and they meet all of those termination resuscitation rules, you can call for that. I recognize, though, that most providers aren't comfortable with that. They don't really want to, declare that child dead. They want to do everything possible. And so a lot of these patients end up getting transported to Cincinnati Children's, and that's fine. And at least last time I've talked to Cincinnati Children's about this, they are also fine with that. They have tremendous resources to help with the patient and family. And so that is reasonable. But you can, in theory, with a kid, you can declare them dead on scene. I bring this up, though, because I think sometimes what I see happen is that because providers kind of know, this, pediatric patient, we're not going to declare them on scene, so let's just start moving to children's now. And the problem with that is then we end up running a less than optimal resuscitation, because again, now we're in the back of the moving ambulance, which to me is just a less intense resuscitation. I'm not saying it's impossible, but I just think it's not quite as intense of a resuscitation. So even on those pediatric patients, I encourage you to try really hard on scene, right? I think that is the best care we can provide. It's still, PALS, pediatric life, advanced life support, really try to work that patient on scene. But ultimately, if you can't, you're working them for a while, you just doesn't seem like you're going to be able to get them back, but you're not comfortable calling them on scene. I get it. It's a difficult situation. Nobody's saying this is easy. But I still encourage you to try to resuscitate that kid on scene as much as you can. But like I said, Children's does have a lot of resources. It's an option available to you. Obviously, if the scene is unsafe, people usually bring this one up. If for some reason, you're on a cardiac arrest and it is an unsafe scene, the family is panicking, it's becoming dangerous. Sure, I get it. Obviously, your safety is number one. That's fine. And, you can transport that patient. And finally, pregnant patients, if you haven't gotten it yet, pregnancy and pediatrics is often the exception when it comes to stuff. Once again, you are not allowed to declare a pregnant patient dead on scene. Again, that is because of the fetus, that if the baby is old enough, we may be able to do a perimortem C-section in the emergency department, and that kid may survive. So in fact, that is the one patient population where sometimes we encourage rapid transport as opposed to working them on scene. It's a pretty rare scenario, extremely rare, but no termination of resuscitation on scene for pregnant patients. All right, so that is it for medical termination of resuscitation. Now let's talk about termination of resuscitation for the trauma patient, all right? And again, similar justification to what we talked about before. When we get into the trauma termination of resuscitation rules, what I want to emphasize more than anything is what we need to do first. Okay, because I think sometimes with these traumas, again, people are maybe a little too quick to be like, oh, there's nothing we can do, it's over, may I just call for the termination? And that's not what the protocol says, okay? The protocol actually says you need to do some things before you actually assess if we can terminate that resuscitation, okay? And I've listed them for you right here. All of these things should be done immediately when you get on scene. Again, caveat, if they're dead, right? We talked about that before, then you don't need to. But assuming they don't meet any of those dead criteria, this is what we should do first, okay? Number one, if they have an injury that is compatible with a tension pneumothorax on either lung, right, we should do a needle thoracostomy, okay? And it is not unreasonable to do a bilateral needle thoracostomy, again, if the mechanism of injury is consistent with that. We do this all the time on air care. If we arrive and it's a car crash, and now the patient's in cardiac arrest, we will very frequently needle decompress both sides of the chest. Again, they're already in cardiac arrest. They're already dead, not dead, but they're already dead. I don't think you're going to make the situation worse. I would go ahead and do bilateral needles if the mechanism of injury is consistent with that. Any blunt trauma, fall, car accident, it's definitely on the table, right? Obviously, gunshot wound to the chest, it's on the table. Okay? We need to, once again, manage that airway. The protocol doesn't specifically say what that means, but we just need to make sure that we're getting breaths in, right? We need to, can we bag them? If we put a supraglottic down, is that working? If we intubate them, is that working? We just need to manage that airway somehow. That may even be a cricothyrotomy, right? A needle cricothyrotomy. Not something that anybody feels comfortable with, not something we do frequently. If you haven't done one, on a mannequin recently, I would encourage you to do so, but that might be needed. If the gunshot wound, is a suicide attempt, that went into the back of the mouth because they turned the gun on themselves, right? We may need to do that cricothyrotomy. So we need to manage the airway somehow. We need to obtain IV access, and then we should be giving a fluid bolus. Some of you may be, savvy and remember that, we often talk about permissive hypotension in trauma patients. So that's the idea that, in a trauma patient who's awake and alert and talking to us, we might allow the blood pressure to be a little bit lower. But that is not the case when we're talking about a traumatic arrest. Okay, the patient is in cardiac arrest. We have to do everything possible. And one reason why they may be in cardiac arrest is because they have simply bled out so much blood volume, they don't have enough fluid in their arteries and veins to circulate. So we need to give them fluid. Now, obviously, some of you who are really savvy may say, yeah, well, but, crystalloid giving, normal saline or lactated ringers, that's not really the best thing. Blood would be better. Sure, absolutely. Couldn't agree more. But most of the, EMS agencies here aren't carrying blood for obvious reasons. And so we give what we can. Go ahead and give that big fluid bolus to try to see if that gets that pulse back just because they have lost so much blood. And obviously, similar to that, stop any obvious hemorrhage you see, right? If the patient is obviously bleeding out from an open leg wound, put a tourniquet on it or something, right? So I want you to keep this in mind. When you come up on that bad trauma patient, it's not, oh man, I think it's over. No. Let's do these things first. Boom, 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 boom. And all of these things are pretty quick. This is not going to take you that long, to do. Another one, I just popped into my mind again, stopping obvious hemorrhage. Another one would be pelvic injury, right? If you palpate that pelvis and you feel like it's unstable, bind that pelvis. That's the same thing as putting a tourniquet on the leg. So I just want to make sure I mention that one. But let's do all these things first, okay? It shouldn't even take that long. If you have a whole team there, honestly, this is probably 10 minutes, maybe not even, okay? This is actually probably shorter than a medical resuscitation. Okay, if after we've done all of those things, now we put them on the cardiac monitor. So that's the key. We do not put them on the cardiac monitor until after we've done all the things I just said. Okay, now that we've done that resuscitation, we've done those 10 minutes, okay, now we put them on the monitor and we see what the rhythm is, okay? And basically, if what the protocol says is that if the rhythm at that point in time is either ventricular fibrillation, ventricular tachycardia, or pulseless electrical activity with a rate greater than 40, then that patient gets transported, obviously, to a trauma center, okay? If it is PEA less than 40 or the rhythm is asystole, then you can terminate, okay? But the key here is that we do that after the intervention. Why? Because say you have somebody who has a big tension pneumothorax, okay? And if you put that cardiac monitor on them right away, they may have a terrible looking rhythm. Maybe they have PEA, at a rate of 30 or something like that, because that heart is just being crushed by all the pressure in the chest. But guess what? If you relieve that pressure by doing a needle decompression, all of a sudden, boom, they could get a pulse back right away. So this is why we don't want to put that monitor on right away. We want to do the interventions, then we put the monitor on, right? Very different than a medical resuscitation. Very, very different. Also, similarly, what's different between a trauma and a medical resuscitation is that, all these interventions, this is what's really critical. Let me go back for a second, just so we make sure that we look at this. This is what's really critical, okay? Notice what's not on there. what's not on there is CPR, is basic like chest compressions, okay? Now, the protocol does say to do CPR. So I'm going to be careful here. I'm not telling you don't do CPR, okay? But what I am saying is that CPR in someone who has a tension pneumothorax isn't going to help, okay? That needle decompression is what's going to help. CPR in someone who has lost all of their blood on the side of the road, what are you circulating? You're not circulating anything with CPR, okay? Getting the quick intravenous access and getting fluid into those veins, that's what's going to help, right? So I want you to focus on these things, less focus on the CPR. Manage the airway. We're still going to do chest compressions, okay? But I'm just saying what I have down here is what's critical. Do that first, okay? Then we can assess the rhythm, okay? Very different, right? Medical arrest, we're usually putting that monitor on immediately, right? Because A, we want to know what rhythm they're in, because that defines some of what we do for ACLS. And obviously, if they're in a shockable rhythm, we're going to shock them immediately, right? So I'm telling you, totally different here. Medical, monitor goes on right away. Trauma, monitor gets on late, okay? Medical, high quality CPR is everything. Trauma, high quality CPR, less important, all right? So I hope that's clear. I'm not trying to make black and white statements here, but these are the ideas that I want you to think about. All right, there's always exceptions, right? And shocker of shockers, pregnant women, once again, the exception for the same reason, okay? Perimortem C-section may be successful, so the pregnant patient gets transported regardless, okay? And if it is an EMS witnessed penetrating traumatic arrest, that one also gets transported no matter what, because that person has a chance of surviving. Some of you may know that when it comes to traumatic arrest, a penetrating injury, i.e. stab wound, gunshot wound, has a slightly higher chance of survival when compared to a blunt traumatic arrest, i.e. car crash, fall, something like that, okay? So if it is a witnessed penetrating trauma arrest, that means like you showed up, they had a pulse, and then boom, you watch them go into cardiac arrest. Get them to a trauma center as fast as possible. That patient gets transported right away. Still, though, let's not forget these interventions. We still want to do these things, but for these patients, the pregnant patients and the EMS witness penetrating trauma, that's the one that I would say go ahead and do the resuscitation in the back of the ambulance. Let's get moving to that trauma center because, we may need a trauma surgeon very quickly to do something. We may need to do a perimortem C-section, whatever. But still, let's try to do those interventions en route. Okay, so that is traumatic cardiac arrest and when we are allowed to terminate.